Welcome back to boot camp, everybody. So in this video, we're going to talk about another very high yield and commonly tested nephrotic syndrome, and that is diabetic glomerulonephropathy. So first, let's look at the pathophysiology here. We know that diabetes is dealing with hyperglycemia, or high levels of glucose and sugars in the bloodstream, and this can lead to a process called non-enzymatic glycation. And what that means is, if we have a bunch of sugar molecules in the bloodstream, they can undergo a reaction, which does not involve an enzyme, hence the name non-enzymatic glycation, that binds these sugar molecules to various proteins. Now, because in diabetic glomerulonephropathy, these glucose molecules can get through the endothelium, this process of glycation can actually also occur in the basement membrane of the glomerulus. And the glycation of this basement membrane can actually cause a thickening in the arterioles. This can create a more narrow lumen or a more stiff lumen. And I specifically drew this on the efferent arterioles. And the reason is that this process preferentially affects the efferent arterioles. And as you recall, our afferent arterioles arrive at the kidney, and our efferent arterioles exit the kidney. You can also remember that A comes before E in the alphabet, and thus the afferent arteriole occurs before the efferent arteriole as well. Why is this important to consider? Well, if we notice that we're having this process called hyaline arteriosclerosis, and it's preferentially affecting the efferent arteriole, what do you think is going to happen to the GFR in the kidney? That's right, it's going to increase, because if we decrease the efferent arteriole, thus we decrease the ability to get blood out of this side of the kidney, it's going to cause a pressure buildup inside the glomerulus, and thus more substrate is going to be filtered, giving us an elevated GFR. Additionally, not only are we creating a greater obstruction for getting blood out of the glomerulus, we also see afferent arterial dilation. And so now if we look at our picture, we not only see the constriction of the efferent arteriole over here, we would actually expect to see this side increase in its width. So it would look something like this. So as you can see, we have an increased amount of inflow because we have a dilated afferent arteriole, and we have a decrease in our outflow because we have a constricted or an efferent arteriole that's undergone arteriosclerosis. Again, this ultimately has what effect on GFR? Well, it increases GFR because by increasing the capillary pressure, we're causing more of it to be pushed through the Bowman's capsule and ultimately filtered into the nephron. This is important because this is actually the first stage of diabetic glomerulonephropathy, and this is called hyperfiltration. So the hyaline arteriosclerosis leads to hyperfiltration and ultimately glomerular sclerosis, or scarring of the glomerulus. So the question is, how does the body respond? Well, we have certain cells within the glomerulus called mesangial cells, and when these cells are undergoing this high pressure state, they act to respond by attempting to create a more supportive structure. These support structures can be added in a uniform manner throughout the kidney, or it can be added non-uniformly in kind of nodules, which we call Kimmel-Steele-Wilson nodules. This is an important image to be mindful of in the diagnosis of diabetic glomerulonephropathy, where you see these very dark pink nodules within the glomerulus. These are essentially tiny balls of protein that the glomerulus creates as a response to the stress that it's undergoing due to the increased pressures in the kidney. On this light microscopy, we might also see glomerular basement membrane thickening and mesangial expansion. Remember, anything that disrupts the basement membrane, in this case thickening, is going to affect its ability to do its primary job and will often lead to a deficit in its ability to filter the appropriate substances. So the GBM thickening, counterintuitively, can actually allow more substances to get through that would otherwise not be allowed through in a normal, healthy glomerulus. Next, let's take a look at some of our management options. So it should make sense to you that if the primary problem with diabetic glomerulonephropathy is the condition of having diabetes, then glucose control or diabetes management would be one of the primary things we would want to do for these patients. However, it's also important to know, as with many other nephrotic conditions, we want to keep up with symptomatic management as best we can for these patients. Remember, as with all these nephrotic conditions we talked about in the first video, some classic findings, right? Hypoalbuminemia, low antithrombin 3, high levels of lipids, low immunoglobulins. These are all things that we want to consider in a patient that has nephrotic syndrome. And again, we also talked about how these patients can get an activation of their RAS system. And so using something like a RAS inhibitor can be beneficial to help manage their symptoms as we work towards improving their primary cause of the condition, which in this case is diabetes. Now, it's important to keep in mind that if we don't manage these symptoms and we don't improve this patient's underlying pathology, we can ultimately get to a point where our hyperfiltration can actually become a decrease in filtration after the kidney has experienced enough damage. So in the long run, this actually causes decreased filtration, which leads us to an important association, is that this commonly leads to end-stage renal disease in patients who are not treated or are not managed for the condition early on. So in summary, this condition of diabetes can actually start as a fairly unknown thing to a patient, right? They might just be having changes in their kidneys. They might be having what we call microalbuminuria, which is small amounts of albumin in the urine, but over time, this is a progressive disease. This can become worse and worse. Eventually, this can develop Kimmel-Steve-Wilson nodules, which is a classic finding, and that's these dark pink sclerotic findings that we could see in the glomerulus. And if the condition is not treated, it can progress further and further to ultimately lead to end-stage renal disease in a patient, which of course is going to cause them to have a decrease in their filtration compared to the early stages when they were having an excessive filtration or hyperfiltration. So while in this particular video we are talking about diabetic glomerular nephropathy and its relation to a nephrotic syndrome in the kidney, it's important to know that patients with diabetes often have other organ involvement. Some of the more common ones include the cardiovascular system or the heart, as well as the eyes, which they can develop retinopathy. So sometimes this might present questions to them as a patient who has a long history of diabetes. They might give you this image where they show you the Kimmel-Steve-Wilson nodules, and they'll ask you for what other associations or what other organs, what other exams should we check on this patient during their visits. Well, one of those answers could be an eye exam, right? Patients with diabetes need relatively frequent eye exams so that we are on the lookout for things like retinopathy. All right, great job, everybody. That wraps up our nephrotic chapter. So remember, all of these conditions share kind of the similar symptoms of a nephrotic syndrome. They might have edema, they can have elevated levels of protein in their urine or proteinuria. A number that's commonly used for test-taking purposes is greater than 3.5 grams per day. But within that big group of nephrotic syndromes, there's a bunch of subcategories or different types of things that can cause the nephrotic syndrome appearance. And so with that said, I will see you on the next chapter where we'll talk about the specific types of nephritic syndromes that are commonly asked about on test day.